Yeah, maybe? Okay, great. All right, thank you everyone. I'm very happy I can be here. Admittedly, my talk is more for the DP audience. If you're thinking, I do DP, but I don't really do healthcare. That isn't my thing. This talk is for you. Although I was asked to give a brief, a 30-second intro to differential privacy, you'll be seeing more on the technical content in the slides that will follow in the rest of the workshop. At a very high level, 30-second version, differential privacy promises that if you were to change one person's data or one entry in your database, however that is defined, then you would still have as output approximately the same response. And this approximation is captured in a probabilistic sense, the probability that you would output anything with that entry is going to be close to the probability without that entry. I don't have a formal mathematical version, but I'm sure you'll be seeing lots of this. And as you saw in the previous intro talk, this has gone from a hypothetical mathematical definition into a very, very advanced field. We have open source libraries, we have companies and governments using it, and it's quite advanced. So let me tell you about my journey. So as Salil mentioned, I really work very squarely in the space of differential privacy. And since roughly 2013, I have been a differential privacy researcher. I work on things developing algorithms, proving theorems, implementation, usability. And then last year, my son died. And healthcare didn't have enough answers. And I was how have those scientists not solved this problem yet? And then I realized I was a scientist, and maybe I could help solve those problems. And so this is my journey into the space, is I'm really coming at it without a healthcare background. And my question is how can I, as a scientist who does lots of stuff with data, think about privacy? How can I contribute in a meaningful way to save lives? And so this is the a question I asked myself. And the first answer is general data science stuff. And there's lots of data problems in the healthcare field, and so I could work on those. But I think this is maybe not quite the right question to be asking. Instead, I think that this is the right question. What can I contribute as a DP expert with the skill set I have, and presumably many of you in this room have? What can you do with that skill set in this area? So to me, it was a big a question mark, and I started thinking. And differential privacy promises many things which are wonderful, and this is the reason why we are here. The most important is that it promises formal, verifiable privacy guarantees. They are not ad hoc, and as long as you implement things correctly without bugs, you will definitely have the privacy guarantees that you think you will, and that is incredibly important. We have also, in the past 20 years, developed a very broad toolkit, as you saw in the last talk. You can just download Python libraries and R libraries and Go. It's wonderful. I want to call out in particular a private synthetic data generation, where you can take in a data set that requires privacy, do some algorithmic stuff, and you'll get out a new data set that can be used and will have these formal privacy guarantees, which is very, very desirable. And we have great accuracy guarantees. I say mostly because this is an active research area and we're always improving, but for the most part and for most things you want to do, algorithms perform well. And I then compare that into what's going on in healthcare. Well, they have lots of data, very sensitive, requires very strong privacy guarantees, but it's also incredibly valuable and is oftentimes underutilized. in part because of privacy concerns, is you can't just hand out medical records. And they also have lots of problems that can be helpful to apply some kind of advanced data science tools. One thing that is worth calling out is the a legal question. So in healthcare, it's not just morally we should require privacy. Of course we should. We also legally have to protect privacy for things that I'm covered under HIPAA in the US or under other laws elsewhere. And there's some ongoing work on the DP and law space. I want to point out Deloni's talk yesterday that is exploring this. I won't say it is solved, but there is lots of a very promising work happening. So the really obvious thing to me is we should just use all these existing high-quality, vetted, different private algorithms, generate synthetic versions of these healthcare data sets, share them widely, lots of scientists are doing research, human lives are saved, and we're all happy. And I was why hasn't anyone thought of this? But the number one rule when you are working, especially outside of your field, is to listen before you speak. And this is very important because I think oftentimes we feel I'm an expert in differential privacy. It was I mentioned before, I have a hammer, I go around looking for nails. And that's usually not the best recipe for impactful work. So I taught a class on this, healthcare applications of machine learning and privacy. And because I'm not an expert, I got a ton of guest speakers. And it was fantastic. And they came and they told me, what is their job like? What are they annoyed about of all these machine learning people coming in trying to solve their problems? What are their actual problems day to day in the hospital or in the lab? And it was very, very informative. And so that's what I want to share here. As it turns out, there's a lot of barriers as to why we can't do this obvious thing. And the first one is that actually, from the a corporate level, there's not really an incentive to share data because this is intellectual property. It is in fact very valuable monetarily, and they want to keep it that way. And so while it's convenient to say I'm not sharing data because of privacy, actually you're not sharing data because you want to monetize it later. And there may have been cases where it's bad for them to share, for example, at a pharmaceutical company who is if you find something about their drug not working, they will have to pull their drug. Additionally, doctors don't always even have access to their own patients' data. So there's a lot of politics going on inside of hospitals, research centers, and it's it's my patient, but it's your machine, and it's somebody else's server, and there's a lot of politics in terms of who gets to make decisions about the data. And so just if you find a really cooperative and friendly doctor doesn't mean you can get their data. And there's also just a physical a technical barriers. It's a lot of these machines are not even a downloadable data. I talked to one doctor who spent a year and a half trying to download data from her own machines because she just couldn't access it. One more big problem is there's lots of missing data. And in particular, it is missing not at random, which from the a mathematical perspective is the hardest case to handle. And in particular, for example, if there's no test results of a kidney blood test, it's because the doctor thought it was important to not order it. And so the content of the data that is missing is correlated to the thing that you want to learn, and that makes it just mathematically hard to address. And so if you want to just think about the a math problem, this on its own is a great problem. Is how to reconstruct missing not at random data, and even separate from healthcare, but this appears all the time. And lastly, although doctors are open-minded and they believe in science and they want to help and they want to to sort of like, contribute, they have not like attended workshops like this, and they are not really bought in to the magic of DP. And so you have to like, convince them this is a great thing, but also they're like, busy people with like a different expertise and so on. So let me end with sort of like a lessons learned so far, because I'm sort of at the beginning of this journey, and I expect there will be more, but these are the key ideas. First of all, is it like a theorems, like do not convince doctors. They also like don't convince lawyers. And so just because you have an amazing paper in stock doesn't mean you're going to be able to sort of like convince a hospital system to share data. One more thing is that like clinicians are very busy. And so if your tool requires them spending 45 minutes on a patient to sort of like make an evaluation, it will not happen. It has to be like 5 seconds or less. And they also get a lot of like pop-ups and alerts, and so just having a pop-up is not helpful. And so you also have to think about how to sort of like integrate it into their workflow. In the hospital context in particular, adoption is very slow. And so even if you have a tool that you build designed for like a specific healthcare application, it's amazing, you can expect on the order of like 10 years before that tool is actually like deployed in a hospital setting. Which is not to say it's like, don't do it, but it's not going to be in the context of like 6 months. I'm going to say like I had it in the hospital, and so as you're thinking about like doing that research in this space, you can say like I'm going to do the first phase and then like pass it off to a different team, but just sort of understand that's how the pipeline works. We got to talk a lot about like accuracy in the machine learning case, as we can say things like I will have a low like L2 error of my like a classifier. But if that isn't what is like a clinically important, then you haven't really helped. And so also thinking about the right sort of like a metric is important, and like talk to your like peers on the other side of the fence for that. And importantly, if you're going to have a useful algorithmic output in a like a clinical setting, it has to be like actionable in the sense of like there's an intervention doctors can do based on this information. It has to be like medically relevant. So if you can like predict something that is not important, doesn't help. If you can predict something important, great. And it also has to be like a timely in the care process, meaning that somehow like you can predict it faster than like the doctors in real time would know about their own patients based on the observation. And the number one lesson is you should like talk to the people who are using your tool, whether it is a clinician or like a researcher or like a patient outreach specialist. Talk to them and make sure what you are building is actually useful. I want to end on a positive note, because a lot of this is sort of like don't do this and don't do that. And the positive note is that like the promise of DP is very real. It's an amazing like technology. We have toolkits, we have machinery, we have theorems, we have code. It is wonderful. But it's not quite as like easy as it seems of sort of like run my code on this data and I'm done. And it requires a lot of like meaningful collaborations with sort of other parties across fields. But there are so many open problems and so much work to be done in this space, and we need like lots of different skills. And so sort of like whatever is your toolkit in like your work, there's space for it here. And we're going to see like lots of talks on this in the rest of the day and tomorrow, and in particular 2 more talks in this session on sort of like a level setting and background that will go into more of the like technical details. Thank you.